We're going to be talking about levels of selecting levels in long posterior cervical fixations and what we mean by especially distally. So what are we talking about here? Basically, what we are discussing is when you do a long segment fixation for a spondylotic spine, you need to stop at C7, or can you cross the border into the thoracic area? And which is better. So why are surgeons trying to cross the CT junction in a cervical problem? What are the reasons? The reasons are fairly obvious. Cervicothoracic junction is a junctional area. It's a junction between a lordotic cervical mobile spine to a rigid kyphotic thoracic spine. And we know from biomechanical principles that when you end a fixation at a junctional area, there is always a chance of an accelerated degeneration of the junction, which can lead to problems like distal junctional failure. It can lead to non-unions and hence lead to the operation, increase in the operation. So this is what the controversy is about. Stopping at C7 comes with its own advantages. It's a shorter fusion. There's less muscle injury. Neck pain is likely to be lesser, but it comes with the problems of a possible distal junction failure or a non-union. Whereas going into the thoracic spine will involve a more aggressive surgery, but at the same time will give you more reliability with your instrumentation, and you're likely to get more reliable anchor points. And the literature is equally divided on this, as usual in many of these controversial topics. And at the same time, there's not much high quality literature actually available on this, and this has really taken the notice of spine surgeons very recently. So we're just going to look at some of the papers which are something which where good research has been done, which has been done methodically. So one of these papers, which was published in 2016. Now this group looked at their patient. It was a retrospective cohort. 219 patients. They looked at all the radiological parameters. They looked at the reoperation rates. And what they concluded was it was better to extend the fixations to T1, because if you stop at C7, the revision rate was almost double. So for a C7 ending fixation, it was 35%, whereas for T1, it was 18%. However, the study had its own limitations. Only 69 of these patients had a radiographic follow-up, and the authors were not sure why the patients were revised. So they were not sure whether it was only a C7 pulling out, or whether there was a C3 failure, or was there something else. So this paper did come with its own limitations. Another multicentric meta-analysis which was published, this looked at 6 studies, because that was all that was available at that time. 4 of these were comparative studies. And what they found out was that the fusion rate was better with the crossing group, but the reoperation rate was lesser when you cross the CT junction. Then there was this paper, again by the Japanese group, again published in World Neurosurgery in 21, which said that the results radiographically or the clinical outcomes or the GOA was similar. There was increased surgical time, increased blood loss, and complications in the patients where you had tried to go across the cervicothoracic junction, but the instrumentation failure was lesser. So this paper talked on both sides. Then there were papers which are in favor of stopping at less than C7. So this was a multi-center analysis which said that there was no difference in clinical and radiological outcomes, but there was increased morbidity, there was increased blood loss when you try to cross the cervicothoracic group. And so there are many papers which go on like this, but I'm going to talk about this paper a bit, which was from the Korean group. They also compared their cohort, and what they found out that there was no radiological difference between the two, but what they found out is that if they looked at their neck disability index, the group which had ended at C7, they did better in terms of pain intensity, in terms of lifting, in terms of where more muscle strength was required. Otherwise, it was similar to the upper thoracic group. And probably the reason is because C7 spinous process is a very important structure, because it has a lot of muscular attachments. The long extensor muscles of the neck get attached to the C7 spinous process, the splenius capitis especially, and the transverse fibers of the trapezius get attached to the C7 spinous process. Also, rhomboides minor originates from the C7 spinous process, which is a very important scapular stabilizer and has a direct bearing on the neck pain. So if you're trying to do a fixation up to C7, and if you are trying to limit yourself to C7, then you may get away by taking off the muscles up to the superior part of the lamina, and you can get your instrumentation in. So you don't need to sacrifice the muscles which are attached to C7. However, if you are trying to go to T1, then there is no way you can avoid stripping the muscles from the C7 spinous process. And there's a lot of muscular damage which happens once you extend to one level down. And this can lead to a lot of muscle damage, lot of muscle weakness, and neck disability. So probably this is something which is very, very important to understand. Now this is the last paper which I'm going to just show. This is very recently published. It's a meta-analysis. It has taken care of all the studies which have been yet published. And they have extensively gone through all the papers and selected 8 articles for the same. And a total of around 1,200 patients were looked into this. And they came up with the conclusion that fusion, complication, and reoperation rates did not differ significantly. And with the C7 LIV, the mean blood loss and the operative time was much lesser as compared to when you try to extend into CT junction. So just a couple of representative cases. This is 3-level myelopathy, 3, 4, 4, 5, and 5, 6. And what we have tried to do here is, I'll just take a minute. What we have tried to do here is restrict ourselves to C7. However, in situations like this ones where you have compressions which are extending well below into the subaxial cervical spine, probably to get enough decompression, these are the cases you would have to probably extend to T1. So from my side, the take home is always consider what you're getting, the cost you're paying, and what benefit you're getting by crossing the. Stopping at C7 does not mean that it is going to increase the risk of distal junctional failure. Unnecessary extension of fusion into the thoracic spine can lead to increased neck pain and difficulty in heavy work. So the thoracic extension may be limited to patients where bone quality is poor, or the C7 fixation is poor, or there is a significant spondylosis deformity at the C6, 7, C7, T1. Thank you.